ADR, different techniques in different scenarios. My presentation is mainly to give a perspective, or mainly a planning perspective in cases where you choose to do an ADR. So generally how we end up in using ADR in CTO PCI is either it's after failed or halted antigrade wire escalation, or failed or halted antigrade and retrograde wiring, or sometimes ADR as a direct first strategy. This third one, even I have not done yet. So most of the times, my circumstances were either after failed antigrade wire escalation or failed or halted antigrade and retrograde. I'll show you a couple of cases. I'll start with an instant CTO, LAD CTO. This is not theoretically true ADR, but we use all ADR techniques in such scenarios. You can see this is instant CTO of LAD. So wherein it's an instant CTO in proximal LAD. So which is nearly short segment. And these are the right cases, where you can use a cross bus to cut short your procedure. So you can see this is the proximal end of the stunt. So always position cross bus into the stunt. So this is very, very important. And then start, your spin advancement. So you can basically reach your distal lumen, within no time. It's a fraction of, seconds. You can go down, and then you can complete your procedure. So then you can exchange your wire to workhorse wire through the cross bus, and then you complete your procedure. And so basically, in instant CTO cross bus reduces your procedure time significantly. And also, this is another instant CTO in proximal RCA. So you can see, so it's a long segment total occlusion within the stunt. So there is an amplitude guide. So you need a good support for, cross bus advancement. So you can see, but there is no, to further enhance my guide support, there is no place to do even anchor balloon. So what I did again in this case, so I positioned the cross bus into the proximal part of the stunt, so into the stunt struts, and then you can see here it is within the stunt struts and started advancing it, but you can see the guide is just jumping out. So the guide is not supporting, so in that immediately we switch to our next strategy. So the next strategy, what I used here is I used a knuckle wire through the from instant. So to advance knuckle again, you need a support. The reason for failure here is basically lack of support to the cross bus advancement, and knuckle needs more support than cross bus. So what I did, so I basically trapped my microcatheter within the proximal RCA. And then I tried an antigrade wire escalation, but antigrade wire escalation with Gaia 2 stalled here. So immediately we switched to a knuckle wire. So with microcatheter trapping with the balloon, you can see here. So I trapped microcatheter, that is antigrade cord side, with a 3 millimeter balloon, and then advanced knuckle. So we could advance knuckle down, and which in fact creates a wide space and makes your subsequent device advancement much easier. So, and we completed procedure, subsequently. So these are the two basic techniques, which we use for most of the ADRs as a dissection strategy. And for an instant CTO, it is a quite easy strategy. So now I come to a long RCA CTO, as well as CTO of LAD, but patient had only viable RCA territory, and LAD territory was non-viable. So you can see this is CTO of RCA. It's a long RCA CTO, almost from proximal to nearly Crux. And this is an LAD, occluded LAD, but there is a good collateralization into the distal RCA, which is well visible here. And this is the overall coronary anatomy, which we can appreciate here. There is a clear cap here. but it's a very long segment with a small island of filling, which is visible in between. So we started doing antigrade wire escalation for this case. Of course, it is very difficult to complete this case in antigrade wire escalation. And then we did a parallel wire, keeping this island as a target, but I couldn't reach the true lumen distally. So then we switched to ADR. So yeah, so what's a plan for ADR? So the first thing is we have to choose a re-entry zone. You can see here, so there is a good re-entry zone before the crux here. So this is the re-entry zone which I have chosen. And once you fix your re-entry zone, then step 2 is enhance your guide support. So I had an AL guide sitting here, so which gives an immense support. And once you made sure, if you had any issue in support, we can also use this as for an anchor balloon. So once you have your guide catheter support enhancement, then you think of what is your dissection strategy. In this case, already my wire is in, so I can dilate with a 1 mm balloon here and create a space. So dilate with 1 mm balloon in this segment, create a space, and from here you can advance cross bars till this point, that is till distal re-entry, so that you can do a dry re-entry. So what we did, so I dilated with a 1 mm balloon, you can see here, and then advanced cross bars into this segment, you can see here, and then so I removed wire and we advanced cross bars with spin advancement, and subsequently the cross bars stuck at this point. It was not advancing beyond this point. So then I realized it is some calcium sitting there, because of which it is not advancing. Then we pulled cross bars back and took a knuckle with a filler XTR wire. You can see here I advanced knuckle wire. So we advanced knuckle wire just to cross pass this part where it is stuck, and then I advanced cross bars over the knuckle wire, and subsequently, and from here we advanced cross bars to the distal re-entry zone. So this is the re-entry zone, and till that point, we advanced cross bars. You can see this is the cross bars and this is the re-entry zone, and then we switched exchange to a stingray balloon using a miracle wire as a support. So this is a stingray balloon, we did a stick and swap. So stick with the stingray wire and then swap with the pilot 200 wire. So, and we completed procedure. So the strategy which I used in this case, so this area we dilated with a 1 mm balloon. Then we advanced cross bars here till this point. It was stuck here. Then I used a knuckle wire just to cross that point. And again, then I used cross bars, to reach distal entry part, re-entry zone for a dry re-entry. So, and this is the final result, we have got in this case. So I'll go to the next case, another case with the RCA CTO till Crux with the ambiguous course. So in this patient, you can see here, it's a long segment RCA occlusion. And you can see there is a good retrograde filling into the RCA, but PDA is almost coaxial with PLVB. So, and the angle between PD and distal RCA is, PD and distal RCA is quite horrible. And this is a very long CTO. And this part of the vessel course is not clear. So, which is very, very important, while doing intervention. So this is what I'm talking about, the angle between PD and PLVB. PDA is more coaxial with PLVB, so which predicts, the failure of antigrade wiring also. So in this case, directly I went retrograde fast, and you can see this is a retrograde wire. I reached PDA, but that wire is just going into PLVB. So I tried turning the wire into distal RCA, but it was not going beyond this point. Whenever we are advancing microcatheter is taking this loop into the PLVB. So that's where we switch to ADR. And again, the step one is choose your reentry zone. So in this case, there is a big side branch here, but we have chosen reentry in this proximal PLBB branch. But the flip side is, so you may occlude PDA. So you should have a strategy for PDA flow. So in this case, as the wire is already inside the PDA, if I re-enter beyond this point, so I can always perforate back and externalize and create flow into PDA. So whenever you have an access to your branch, you can always still consider ADR as an option. And the next step here is this enhancement of support. So we can use already AL guide is here, and I can also use anchor balloon to enhance support. So which I did here. So and what is the dissection strategy in this case? Of course, there is an ambiguity in the vessel course here. So I decided to go ahead with the knuckle beyond the proximal cap till this point where the knuckle becomes coaxial with my distal wire, and from there I can advance cross boss because once the path is clear. So with that plan we started ADR. So we can see this is a knuckle wire with a fielder XTR, and advanced knuckle wire along with microcatheter advancement, not allowing knuckle to expand big. And then at this point, I advanced to cross boss, and then from there we took cross boss for dry advancement, dry re-entry at Crux. So we advanced to cross boss till Crux. You can see here now cross boss reached Crux, and then we took a. We can see this is the strategy which I used here. So microcatheter was sent here. Then we took a knuckle wire till this point, and subsequently we used a cross boss for final dry re-entry. But fortunately, in this case, what happened is when I sent a miracle wire, that directly went into lumen, which you can see here. So cross boss actually entered into true lumen even before the PDA. So I was also confirmed it, and subsequently we stunted the whole vessel, and we can see this good result, which we have got. So this is another case of post-CABG with calcified RCA CTO. These patients really pose a problem, for any CTO interventions and also for ADR. Mainly because of multiple collateralizations which we see in post-CABG patients. So this patient, the left system is okay. So, and this is the right coronary artery which is totally occluded, and graft to right coronary artery is occluded. You have a graft to diagonal, so which is and the graft to OM, and this is the graft to diagonal, which is actually filling the PDA. So we can see here, this is filling PDA and also the distal RCA. So RCA is getting flows from LAD and graft to diagonal and also from LCX. So that is a major challenge. So in such patients, visualization of distal vessel is very, very important. So what we did, say we took a dual injection to understand, how the vessel is, but you can see, this part of the vessel is not visible in dual injection. So that makes it quite prominent. We may have to use a triple injection in such patients, if you really end up in an ADR, or shift this catheter to this graft so that, you can visualize your distal vessel. So we started with an antegrade wire escalation, but that ended in, that ended up here. So, and it was not advancing further. So then I tried retrograde, you can see here, but I couldn't cross retrograde collateral. Then I ended up in ADR. So the first step for ADR is choose re-entry zone. So you can see in this case, this is a CT. So, and there is no calcium at this point, which you can see here. So in these three sections, so I thought this is a good point for re-entry. And there is a lot of calcium, across the CTO. So we decided to go ahead with re-entry in a posterior AV groove. And yeah, this point. And then is the enhancement of support. You can see here, we can trap this microcatheter with a balloon, so which gives immense support for your next dissection strategy. So what's a dissection strategy here? So you can start a knuckle within the CTO and advance the knuckle till here. From here again, we can move on to wire-based advancement, that is nothing but a bogey technique until our re-entry zone, so that we can have a dry re-entry. So distal vessel visualization is another challenge here. So you have to make sure you are injecting into the right retrograde vessel for visualization of your distal vessel. So in this case, it is the OM diagonal graft into which I have to inject. So that's what we did here. So with a trapping microcatheter, so gladius wire knuckle is advanced. You can see how the knuckle is going, and it just got advanced. And to my surprise, I realized the wire is in the true lumen. So which I confirmed by microcatheter advancement and then Workhart's wire advancement into multiple branches. So that made my job easy, even without re-entry. So this is what happened in this case. Sorry. So we took a knuckle wire from here, but we thought of doing a wire-based advancement here, but the knuckle wire went into true lumen. So procedure became simple. So this was a result, I have got. So this is another middle LAD CTO. So you can see here, there is an ambiguous cap. So I really don't know where the cap is here. And it's not a clear case for ADR. So what we did in this case is basically we started with an IVOS guided antegrade entry. So we did an IVOS guided entry into the LAD. You can see this is a wire. But after entry, the wire went subintimal. You can see here, the wire went subintimal. So it's in subintimal because of the acute angulation at the proximal cap. So this is a Gaia 2 wire. And then actually I went retrograde. You can see this is a retrograde wire, but I was stuck with the uncrossability of microcatheter. So microcatheter was not crossing both fine cross and court side. So at that juncture, so we decided to go ahead with ADR. That's a re-entry with Stingray. So I have to choose a re-entry zone. So I have chosen this re-entry zone because there is, again, this is distal here, and also there are branches here which I don't want to lose. So this is the re-entry zone. And then we support enhancement because it's a short CTO. You may not need much support for advancement of Stingray. If you need, you can obviously use this subtle for a anchor balloon. So that's what we thought of. And we took a Stingray, we dilated this space with 1.25 mm balloon to create a space for Stingray advancement. And then visualization is not really required in these cases because we have a retrograde wire which can be looped and which will guide us for re-entry. So what we did here is, this is a retrograde wire I looped, and this is a Stingray, so balloon, and taking that as a guide, I took a Gaia 2, and we did stick and drive in this case. And you can see here, we stick and drive in this case, and Gaia 2 advanced further into the true lumen. You can see here Gaia 2 in true lumen, and subsequently we completed procedure. So what we did here, I was guided entry here, followed by created space with 1.25 balloon, then Stingray and re-entry with stick and drive, and using retrograde wire as a guide. So this is the final result which we have got. So this is another case of LAD CTO with LMCA bifurcation. You can see here, so there is a small, entry which is visible in LAD in this case, and also there is a tight lesion and patient denied bypass surgery. So patient also had an RCA lesion which we have treated, and this is not my interest. So I'll just go to what we have done. So we tried wiring LED. So LED wire went subintimally. This is a pilot wire, so which went subintimal. Then we switched to ADR as there was no collateral in this patient to really get into a distal vessel. So we have chosen re-entry point here. So this is a clear re-entry zone. So you can see here, so this is a clear re-entry zone. The next step is support enhancement. Not much support is needed because you have a EBU which gives a great support. And the next thing is create space for Stingray advancement, which we can do with a 1 or 1.25 mm balloon, and subsequently, re-entry with the stick and swap technique. So this is a Stingray. So this is the first stick which I tried. It's with a Stingray wire and subsequent pilot wire, but it didn't go to true lumen. You can see it is just buckling in subintimal space. So what happened here is basically there is a lot of subintimal space created here, but there is a clear lumen visible here. So what I did, I pulled Stingray back at this space. Initially, I tried here where there is more subintimal hematoma, and I pulled back here where there is less subintimal hematoma and retried. So that's bobsledding, which we can do with Stingray, and I again stick with the Stingray wire, then swap with pilot wire. You can see now it is easily simply going into true lumen. So, and later we did, So what happened in this case is basically initially I tried here, later I pulled and retried at the point where it is lumen is clearly visible. So, and this is the final result after bifurcation stunting for this patient. So this is another case of LCX total occlusion. You can see with an ambiguous entry again. So we attempted IVUS guided entry here, but that IVUS guided entry went into the same lumen where into the subintimal space, which was created in the first attempt in another center. So yeah, this IVUS guided entry with slipstream technique, but unfortunately it ended up in a subintimal location. You can see here, even entry itself is subintimal. So, and subsequently the wire remained in subintimal zone and it went into a branch. And we redirected the wire into the main vessel. You can see this is in the branch. I redirected wire into the main vessel, and it remained in subintimal. So, and at this juncture, we decided to go ahead with a re-entry. So this is the clear re-entry zone, which is quite visible. And what we can do is either dilate with 1.25 balloon or advanced cord safe or Caravel, and then take Stingray there. And that's how you can create. And visualization is very important here, as already James spoke about. Put a microcatheter into ramus and inject, and visualize, not direct injection. So, and then you can re-enter. So this is what we did here. So we advanced Stingray balloon, you can see here, and created a, so then we re-entered. So we did a stick with Stingray wire, followed by swap. This is the swap with pilot wire. You can see it just goes in. Yeah, it's going in. And then, yes, so, and we completed procedure. So this is the final result. So of course, as the entry point, still the flow into that vessel is remained. The branch, so it's a good final result. So, sorry. Yeah. So overall, the learning points, is, ADR skills contribute to increase the success rate of CTO PCI. In my experience, it is contributing nearly 10 to 12% of my success in CTO PCI. And the points to ponder, before switching to ADR in any case is choose your re-entry zone, enhance your guide catheter support, customize your dissection strategy for the case based on the anatomy, and visualize your stingray balloon and your distal lumen, and then you re-enter. And we have to prevent subintimal space expansion while planning each step. And we can use straw or bobsledding, to shift your re-entry zone, which might help in difficult re-entries. Thank you.
I thought it was great. I really enjoyed the cases. I loved your diagrams and the analytical way you were breaking down the problems. That's just, I think that's all CTO operators can learn a lot from that planning approach. And it was clear there's a lot of thought goes into it and a lot of skill the way you adapted to the problems in front of you. So yeah, I thought it was a great talk, very enjoyable. And, I think the cases were very complex. So I think it's good for your colleagues to see what can be achieved with that kind of planning and careful attention to detail. And it's clear that you've reflected on those cases as well. And that's something perhaps we don't do enough. It's great to show cases that went well, and it's easy to reflect on, your successes. But I think you make most progress when you reflect on things you found difficult and things you would do differently. And it's clear your mindset is very well adapted to the CTO space. So congratulations from me.
Thank you.